Uh, Good afternoon, everybody. After the heavyweight left heart session, a featherweight person speaking on the featherweight ventricle, the right heart. So, at least a change of topic. Pulmonary hypertension, the thing that has been given to me is a full chapter. So, I'm not going to the very details of everything. I'll just show approach to the whole thing with a special emphasis on selexipag. Pulmonary hypertension, as we well know, it's a right heart catheterization diagnosis with a mean pulmonary artery pressure more than 25. Well, just note that it's a right heart catheterization, which is gold standard. ECHO is running after the gold standard to reach the gold standard, so far not yet reached. So, how do a pulmonary hypertension patient come to you? Why pulmonary hypertension? Either they are referred to you for an echo, or it comes to a pulmonologist or a cardiologist with a set of symptoms. Shortness of breath, syncope, and the flow chart to approach is, first you have to think about probability. What we echocardiographers usually do, we measure the TR velocity, we write that there is a pulmonary hypertension, the thing goes back. Well, this mention of pulmonary hypertension is usually of no use clinically, no use to a surgeon, and no use to anybody. So we must know that when screening patients with suspected pulmonary hypertension, information from echocardiography can only grade the probability of pulmonary hypertension being present rather than provide a definite diagnosis. Therefore, when assessing probability of pulmonary hypertension, measurement of TRV should be used in conjunction with others. Often we call them as secondary signs. So this is the TR velocity. We know that when it is less than 2.8 or unmeasurable, you have only two groups. One is low and intermediate. When it is more than 3.4, well, then the secondary signs do not matter much. So how do you approach for the secondary signs? Other than TRV, in the ventricles, you have to look for flattening. You have to look for that the RV size is more than half the LV size, and the RV isovolumetric relaxation time should be more than 75 milliseconds. In the pulmonary artery, the RVOT acceleration time of less than 105 milliseconds, they give you an idea of mean pulmonary artery pressure, a mid-systolic notching, pulmonary regurgitation velocity, that is early diastolic, that also gives you an idea about the mean pulmonary artery pressure, and the PA, main pulmonary artery diameter, more than 25 millimeter. In the IVC and RA, the IVC diameter is important, and specifically the collapse. Less than 50% with a sniff and 20% with quiet respiration. And RA area is a very reproducible thing. RA area is important, more than 18 centimeters square. So this is a picture starting from the upper left extreme, the RV size compared to LV. Then you have the basal RV diameter and the LV diameter. The ratio should be more than 1.1. You have the IVC. You have the TAPSE, which should be, you know the value, less than more than 20. Then you have the RVOT acceleration time with the mid-systolic notch, the pulmonary regurgitation velocity, both early and end. They give you an idea about the mean arterial pressure. And you have the IVRT, which is more than 75 milliseconds. All these makes it probable. So, first question is pH suspected? You should have these data on the left-hand side, the TR velocity, the pulmonary regurgitation velocity, early diastolic, the RVOT acceleration time, IVRT. Along with it, the size of the RV, the TAPSE, and IVC. By this, you suspect if pH is present or not. If there is more than two signs, two secondary signs with less than 2.8 meters per second TR velocity, that is less than 35 millimeter mercury PS systolic pressure, pH is probable. If it is more than 3.4, you do not need the secondary signs. But if you have one or more feature identified, then you first do the right heart assessment protocol and also associated other causes of congenital heart disease, valvular heart disease, LV systolic dysfunction, the left heart causes of pulmonary hypertension. So if you look at this table, if you have a peak TRV less than 2.8 second or not measurable, PASP less than 35, and you do not have any signs, then your probability is low. But if you have signs, then you are in an intermediate probability that the patient is having PH. If you have 2.9 to 3.4 and you do not have any signs, secondary signs, you have an intermediate probability. But if you do have signs, that is a high probability of having pulmonary hypertension. Similarly, if it is more than 3.4, you do not need secondary signs. It is a high probability of pulmonary arterial hypertension. The right heart assessment protocol includes this. RA area, I already told you, more than 18 centimeters square. RA volume index, where you measure it by area length method. LV eccentricity index. RV free wall strain. Myocardial performance index or TE index. The PVR, which is very, very important to surgeons, and the cardiac output. RA area, this is the way you measure it. RA volume index, the area length measurement. LV eccentricity index. Remember that if it is purely pressure loaded, then there is flattening of IVS and it is increased in end systole. If it is a volume overloaded situation, it increases in end diastole. LVEI end diastole less than 1.7 has a prognostic significance. RV free wall S less than 12 and a VTI of less than 2.5, they are secondary signs by which you can understand pH is present, but it cannot quantify pH. TE index in association with PASP, TE index is nothing but IVCT plus IVRT divided by ejection time. That is the myocardial performance index. Now, this correlates with PASP presence with the pulmonary hypertension. However, it is helpful in prognostication, not for validation. Pulmonary vascular resistance more than 3 Wood units is important. It should be less, but it cannot replace right heart catheterization. Here, cross-sectional area of LVOT you take, LVOT diameter into 0.78. The stroke volume, you know the velocity time integral at the level of LVOT into cross-sectional area. Cardiac output is this into heart rate. So you get cardiac output, you get pulmonary vascular resistance. This is a total right-sided heart study for a pulmonary arterial hypertension, which has to be done. So the diagnostic algorithm is, first you remember that causes. There are, according to WHO classification, 5 different subsets of pulmonary hypertension. Group 1, only the left heart have pulmonary capillary wedge pressure raised. Only the left heart causes. Rest all have a normal pulmonary capillary wedge pressure. In intervention, we call them post-capillary and pre-capillary. Okay? So, group 1, group 3 and group 4 are essentially pre-capillary, that is pulmonary capillary wedge pressure is normal. Group 2 and a part of group 5, they have PCWP raised. Group 1 includes the idiopathic, the heritable, the APA, that is associated lesions, drugs, toxins, primary, the pulmonary hypertension of newborn, and you have veno-occlusive disorders. Group 2 is left heart causes. Group 3 is lung causes. Group 4 is CTEPH, which is very, very common today. And group 5 is with multiple unclear reasons. It can be hematological, it can be systemic, it can be metabolic, and others. So, first you have symptoms which are suggestive of pH. You do a non-invasive assessment compatible with pH. If that is not there, you search for other causes. If it is there, then you have either the group 2 or group 3 with you. You take the specific signs and symptoms. You take ECG, chest X-ray, transthoracic echo, PFT, HRCT. Group 2 and 3 is confirmed. If pH is appropriate to severity, treat the underlying cause. If pH is out of proportion, then you have to do a ventilation perfusion scan. Now, ventilation perfusion scan, there are defects. You either go to group 4, that is CTEPH, or a pulmonary veno-occlusive disease. If you perform now a right heart study, that is what I told you, right heart study, now you have the specific diagnostic tests. If HRCT shows something, you can get pulmonary veno-occlusive or PCH. History will give you connective tissue disorders. You have drugs and toxins through history. HIV you test. You test for TTE, TEE, CMR, which gives you congenital heart disease. The physical examination, ultrasound, gives you portopulmonary causes. The lab gives you schistosomiasis, chronic hemolytic anemia. Nothing is there, it's idiopathic. So this is how you approach to diagnose a case of pulmonary hypertension. But the gold standard remains right heart catheterization. So whatever you do in echo, if you have a true pulmonary arterial hypertension, please have a right heart catheterization done before proceeding further. So the guide to medical therapy is, remember that the pathogenesis are two. There are prostacyclin pathways, endothelin pathways. Prostacyclin pathways are vasodilators, platelet aggregation inhibitors, and antiproliferative. Endothelin pathways are vasoconstrictor and smooth muscle cell proliferation makers. So in prostacyclin inhibitors and endothelin, prostacyclin synthetase activators, because prostacyclin synthetase decreases in pH, and endothelin plasma levels are raised. So if you have endothelin inhibitors or prostacyclin synthetase activators, they help in pH management. Nitric oxide production is impaired. Serotonin, the lung and serum tissue VIP is increased in pH. So on these basis, actually the drug therapy is made. There are genetics, the BMPR2 and the activin receptor complex. They all come together to form the lesions, the risk factors with susceptibility, genetic susceptibility, along with vascular injury, leads to progression. So first, before you go into management, you have to do a risk assessment. In 2009, it was based on disease severity and stability. But after that, it was based now in 2015 on the various hemodynamics, functional capacity, and these. So, this is the patient test risk, the symptoms, the exercise tolerance, the RV function, and the hemodynamics. They give you the risk assessment in patients with pulmonary arterial hypertension. Functional capacity is according to WHO classification, class 1, class 2, class 3, class 4, nothing to say here. So this risk stratification marks, see the high risk one, that is more than 10% chance of mortality within 1 year. They have to have a clinical signs of heart failure, symptom progression, syncope, 6-minute walk distance less than 165, CPET, which is VO2 is less than 11, the NT-proBNP should be more than 100, Imaging shows RA area more than 26. Presence of pericardial effusion due to PAH is a bad prognostic factor. And in hemodynamics, you have a RA pressure and other values that I had been just talking about before. So they constitute the high risk group. And the low risk group is based on all the criteria together. So this is risk assessment. The reason being, we want to diagnose the patient early. So in early portion, they will be low risk. As the disease progresses, they will go to high risk. So the reversal and the future will not be good. Therefore, the management is actually, the lookout is good exercise capacity, good quality of life, good RV function, and a low mortality risk. Earlier the diagnosis, the better is the result. Just 2 minutes I'll take. The treatment consists of endothelin pathway inhibitors, the bosentan, ambrisentan, macitentan. The nitric oxide pathway, you have sildenafil, tadalafil, ricoceguat. And in prostacyclin pathway, all are intravenous or inhalation. Only selexipag is oral. There are complementary combinations. The ERAs, that is endothelin receptor antagonists, along with nitric oxide agonists, they are complementary. All the studies, combination studies, were positive except for a combination of bosentan and sildenafil, which should not be combined. The combination can be rapid sequential, can be upfront from the beginning. Till date, nobody knows which is better. And that is what is there in the conclusion, that we do not know what is the optimal approach, initial combination therapy or rapid sequential combination, because both of them showed good results in ambition study, except in COMPASS study, bosentan and sildenafil combined together gave negative results. So far oral therapies were concentrated only with ERAs, the guanylate cyclistimulants and phosphodiesterase 5 inhibitors. Prostacyclin receptor agonists were there only as IV. Selexipag is the first one which is oral. And in the Griffon study, they showed there was 1156 PAH adult patients were taken, and they showed significant reduction in risk of morbidity and mortality by 40% compared to placebo. That was great. So it concluded that Griffon study with selexipag met its primary objective in patients with PAH. You see the graph, they separate right from the very beginning. The dose titration should be properly done. The starting dose is 200 microgram twice daily. The increase is done by 200 microgram twice daily at weekly intervals to the highest tolerated dose of 1600. But remember, with moderate hepatic impairment, the starting dose remains the same, but increase in dose is only by 200 micrograms once daily. So the take-home point is, PAH is a disease of cardiopulmonary unit affecting the pulmonary arterial and venous circulation and the right ventricle. It is under-recognized global health issue. And current practice guidelines for the treatment of PAH propose a treatment algorithm according to the patient's risk factors. Patients considered lower risk based on clinical assessment can initially be treated with an oral agent, whereas higher risk patients, including those who are with a functional class 4, should receive intravenous prostacyclin. Selexipag is a non-prostanoid agonist, selective for the IP receptor and mediates vasodilation of pulmonary vasculature. Selexipag reduces the risk of a mortality morbidity even by 40%, and selexipag may have better side effect profile than other oral prostanoids. Thank you very much.
The very elegant lecture, Arunangshu, regarding the diagnosis and all the parts of therapeutics. Just I have two questions, set the ball rolling. And number one point is whether we in the ICU generally do an ultrasound or echo, whatever we see the inferior vena cava contraction or the collapsibility. And seeing the collapsibility, we determine whether the loaded or unloaded patient is not. Whether it will depend on that or go for the TAP-C immediately to see the tricuspid, the perineural velocity systolic exertion. if that part is more specific, or IVC collapsibility is more specific regarding this?
No, in PH, not one factor is conclusive. You have to take the whole group together. For example, IVC loading can happen in a heart failure patient also. Heart failure patient, the IVC loading can be for two reasons. One, fluid overload, the other is pulmonary artery pressure.
Correct.
So they combine to make the IVC non-collapsible. But when we are talking only about pulmonary hypertension, IVC is one of the points to be seen. But the other points have to come in conjunction. That is why the secondary signs are so important in detecting the probability of a true pulmonary hypertension.
Regarding therapeutics, one question of the Griffon trial. Would you start the selexipag fast, or rather you try with the mesitantan, bosentan, and
I tell you
then
one thing,
combine together?
I could not show because of lack of time. You have to go in for a combination, okay? Whether you are going to do it sequentially or you are going to do all upfront. This combination means if the patient is high risk, you have to combine ERS, NOIs and selexipag or any IV. High risk means you have to give IV prostanoids. There is no question in it. But the selexipag detailed study shows that there you can, instead of IV, you can go in for oral also in the Griffon style. And you are getting good mortality benefits. IV or inhalation, we often try to avoid. So far, selexipag in this Griffon study, they said that you can start oral in the high risk. In the intermediate risk, you have to have a combination, but that combination can be ERAs and PDEs. Okay. You don't need to have prostanoids there. Combination you have to give. The combination can be sequential also. You can start with a monotherapy if it is a low risk. In an intermediate risk, you can start with the monotherapy and rapidly add the second drug. Or you can start both of them upfront. Because in the ambition trial, the combo, the triple combo has shown the best result in intermediate and high risk group.
Okay.
And dual combo has shown the best result in the intermediate group. Whereas in the lower risk group, monotherapy showed equal result.
And what a mild pulmonary hypertension, you start the sildenafil tarafil first.
Yes.
All L-arginine powder is available of sachets.
Actually, the whole
is
thing is,
vasodilator.
the one step I also could not enter there. First, you have to do, ideally, you have to do a vasoreactivity test.
Right.
If it is vasoreactive, then you go in for calcium channel blockers and this sildenafil group early. Otherwise, if you do not have a vasoreactive test done and you have to go in for thumb rule, then you add the two.
Now, you have shown the classification, recent classification of pulmonary hypertension into 5 groups.
Yeah.
I understand that, but clinically, till now, what I feel relevant is to differentiate primary from secondary hypertension, classify clinically whether it is secondary hypertension, then the treatment modality is different.
See,
Just a minute. Primary pulmonary hypertension has worse prognosis. Treatment modality is a different protocol. Number one. A comment on this. Number two, recently I have seen mesitantan has been criticized and has been found to be ineffective either or is harmful for treatment of primary pulmonary hypertension. Your comment on this?
See, the primary comes in the idiopathic group in group 1. Okay? If you follow the group, this is a total pulmonary hypertension classification. These 5 groups, heritable or idiopathic, that is the primary pulmonary hypertension, which are usually genetically derived. Okay? So in this group, idiopathic and heritable, these two comes in the primary pulmonary hypertension part. The rest all are secondary hypertension. The total thing is secondary hypertension. So when they have classified it in WHO, they included the classification of primary and secondary pulmonary hypertension. They did not make it like that. they took all the causes in it and classified them on the groups based on their hemodynamic findings that you get. Okay. For example, this was actually an extrapolation from intervention cardiology. We were talking about pre-capillary and post-capillary. Okay. So initially there were two types, primary, secondary, pre-capillary, post-capillary. So now if you look at this, it's a comprehensive classification where post-capillaries have been restricted, pre-capillaries have been included, primaries have been included, secondaries have been included. So as you asked, the first group 1 PAH, idiopathic, is the primary pulmonary hypertension subset, which usually affects young women at certain age groups. Okay. Second part, macitentan, yes. The problem with all these drugs are, we are starting therapy on a clinical day-to-day practice. We are not following the algorithm. For example, if we follow the algorithm, maybe the most plausible pathophysiology was a vasoreactivity which is causing the pulmonary hypertension. There, instead of using a calcium channel blocker or a sildenafil, we are using macitentan. Nobody is going into the details. When we are doing a study, we are just taking a person, diagnosing it as pulmonary hypertension, and we are trying to prove and start a drug. Probably that is the reason, because ambistant studies, they give fantastic results. I'll show you the graphs. Just once I'll show. See, this is the portion. That is why, can I have this one? This one, algorithm, can I have this for 1 minute? Can I have this algorithm for 1 minute?
The last time for 1 minute.
Huh. When you make the diagnosis, it's very important that here first you have to do vasoreactivity test. If the vasoreactivity test is not done, then you cannot proceed further according to the treatment algorithm. But vasoreactivity test is not done in clinical practice by everybody all the time. Probably that may be the reason, but I do not know why macitentan
Any
performed.
comment or question from floor? Anyone, please?
Just a comment. Actually, I want to use this chance for that reason. Brilliant presentation by Dr. Arunangshu. Now, it is very important. I want to mention this for this reason, that pH, very clear cut. Last 21 guideline, WHO guideline, defined the pH as possible and probable. Long back, around 2015, ESC in a position statement defined the same way. Very unfortunately, I never saw the echo reports. They are saying possible or probable.
Yes.
In WHO guideline, they categorically mentioned that one shouldn't mention the by millimeter of mercury. You can express either tear gradient or you should say possible or probable. But we used to see, very much we used to see a diagnosis of mild, moderate, severe pulmonary hypertension of 50, 55, 56. There is no such echocardiographic classification or grading of pH. So I was asking for this chance because these impose a very burden on the clinicians. If the echocardiography report said there is moderate pulmonary hypertension, who knows what is the moderate? If you grade it 55 or 56, then what will you do? We'll have to directly that the patient is suffering from pulmonary hypertension. So this point should be noted very importantly, that echo report should be mentioned either it is possible or probable.
Yes.
That should be the rule actually.
Exactly.
Or just express in form of only tear gradient. One shouldn't calculate the PF ratio.
Exactly.
Okay, because lack of time, we will conclude the session here. I think this topic deserves a full day symposium.
Yeah, it deserves so.